and thank you for the invitation to be here and to present. I am from CSL Behring, as you heard, and as a company, we've been in the business of purifying proteins from human plasma for a long time. In the back, I saw on the table there's a pamphlet you can read about exactly how long ago the scientists at the Behringwerke took to the process of purifying alpha-1 antitrypsin from plasma. And I'm always reminded whenever I speak that my job and the therapies that we create wouldn't be possible without the people who donate plasma to make it possible. So I'm going to talk about the effects of intravenous alpha-1 antitrypsin on lung structure. So why lung structure? This cartoon comes from the alpha-1 website. This is the disease. It's a cartoon that shows the effects of alpha-1 antitrypsin blocking the actions of neutrophil elastase, and in the absence of that, the neutrophil elastase does damage to the structure of the lung, and it leads to emphysema. So what is emphysema precisely? Well, this is a typical chest X-ray comparison of a normal lung on the left and an emphysematous lung on the right, and you can see there's a lot more black in the lung on the right, and it's taller, and that's because the lung of the emphysematous patient has less lung tissue and more air in the X-ray, and the air is black and the lung tissue is white, and it's inflated to a greater degree, which is why it seems taller. It's hyperinflated, and those are the hallmarks of emphysema that have been recognized for a long time by X-ray, but X-ray is not really capable of quantifying at the level of precision that you need to understand whether treatment has any effect. So let's go further than that. I'll start in the 1950s, and this is from the pathology laboratory. So people that had emphysema and had their lungs out, their lungs were evaluated, and two researchers named Goff and Wentworth standardized a procedure by which they could evaluate the amount of lung tissue in the given space of the lung, the density of lung tissue, and I'll say more about that in a minute, in a standardized way. And that's what you see a picture of here. They would take the lungs out, inflate them, fix them, slice them, and then literally count how much airway, which is the brown part, was present for a given area. Well, things advanced from there, and now you see a picture of an electron micrograph, so you can actually see the detailed structure of the emphysematous lung. But still, this is not the same as correlating or being able to quantify the structure of the lung. And so enter CT scanning. You probably have heard about CT scanning as a method of taking pictures, three-dimensional pictures of the body. And in the case of the lung, it's particularly useful because the CT scanner is a computerized densitometer. It measures the density of the tissue using the computer to help. And because of that, the CT scan is uniquely usable to quantify lung structure. You can use the CT scan to create these beautiful images. And this is a 3D recreation of a patient from the RAPID study. So this is a patient who, at baseline, had a certain degree of emphysema, which is shown as the black areas on the picture on the left, and then after 2 years had progression of that disease. And this is the typical pattern of emphysema progression in alpha-1 antitrypsin deficiency. It starts at the bottom and moves up, typically. And that's in contrast to tobacco smoke-induced emphysema, which typically starts at the top and goes down. So the CT scan has lots of promise for how this can be analyzed. And in the RAPID study, we used density as the measure. Now, what is density, right? Density, for going back to the physics class, is defined as mass per unit volume. And in truth, what we're seeing in the destructive process that takes place in alpha-1 antitrypsin deficiency is a loss of lung mass. So in order to be able to calculate what the lung mass change is, we need to be able to understand density and correct for volume. So the lungs are more like the balloon than the lead brick. They're filled with air, and we have to account for that. And so the way that's done is to quantify the level of specific densitometric portions of the lung, the 15th percentile it's called, and to correlate that with the anatomic structures. And that was done in a series of studies over the last 2 decades to demonstrate that, in fact, CT density very accurately and sensitively can characterize the changes in lung mass. So that leads us to alpha-1 antitrypsin administration or augmentation therapy. In order for augmentation therapy to be expected to have any effect at all on lung mass, it first has to be present in high enough levels. And when we first developed our alpha-1 antitrypsin protein, we compared it with the first one approved, prolastin, and what you see is over the course of 12 weeks here that the levels of alpha-1 in the blood rise to levels that are well above what's considered to be the protective threshold. And I can tell you that on average, the levels rise into the lower end of normal range with the 60 milligram per kilogram per week dose. And in the course of doing the RAPID study, which enrolled patients for 2 years, half of whom got active treatment and half of whom got placebo, you could see that not only did we elevate the levels, but that those levels were maintained over the course of the entire 2-year period. And actually, we have data extending out to 4 years now. Now, I don't know if it's as easily apparent, but the normal level of alpha-1 in the blood for people that are not deficient is in the high 20s or maybe low 20s. These are measurements taken at the end of the dosing interval. Trough, it's called, meaning that this is just before people got their next infusion. So this is as low as the alpha-1 level ever gets. And as I said, on average, it's around 23 or 22 micromolar, which is the normal, the bottom end of the normal range. Now, previously, in smaller studies, alpha-1 augmentation compared to placebo was tested using CT scan lung density. And the 2 studies that preceded the RAPID trial were the Danish-Dutch study and the Exactly trial. Between them, they had 133 subjects. And they demonstrated when they were put together that there was, in fact, a statistically significant difference in the rate of lung density decline, which is shown in this graph. So the light blue line at the top are the augmented patients, and the grayer line at the bottom are the placebo patients. And what you see there is a 36% difference. So that's a 36% less loss of lung density or lung mass over the course of the 2 years of the study. The RAPID trial itself repeated that experiment, but now there were 180 subjects. So this is a single trial, and it shows the same thing. It shows, finally, in a single trial, a statistically significant effect of augmentation therapy to reduce the rate of lung density loss. And then the RAPID study had a period of extension of another 2 years where all of the subjects who were treated with placebo were switched to active treatment. And that's shown on the bottom line of this graph. The left half is what you've just seen, the gray part being the placebo patients. But if you look at the bottom line, it changes in color to blue because that is when those patients switched from taking placebo to taking augmentation therapy. And what I think you can appreciate is that the lung density decline rate of those patients, the slope of that line changed. And it changed in a way that makes it look just like the patients who started out getting alpha-1, the top left blue line. And what that says is a couple of things. It's important to treat patients early because the longer you wait, the more lung density is being lost. But it's not too late to start patients because even after 2 years of delaying treatment, there still is an effect, and the magnitude of that effect seems to be the same as treating early. Now, I'm sure everyone in the room with alpha-1 deficiency would want to be treated as early as possible. But there are some things to keep in mind, and I'll show them to you in the next couple of slides. The first question is to ask whether or not a change in the rate of lung density lost actually correlates to things that you could experience clinically or that you could experience symptomatically that you would know. And one of the ways to get at that is to compare the change in lung density with the change in another measure. And in this case, I'm showing you a graph from the RAPID study of the relationship between the change in lung density decline on one axis and spirometry, FEV1, on the other. And you can see an upward sloping red line, and that shows a positive correlation. And what it means is the patients that had the lowest level of lung density loss also had the lowest level of FEV1 decline. And that's a very good thing. Now, we know that augmentation therapy can save lives from data that came as early as the 1990s. This is the NHLBI registry, which compared augmented and unaugmented patients, and this shows mortality. In the bottom green line are the unaugmented patients, and the steepness of that line shows how many of those patients died compared to the patients who got augmentation in the top two lines. So we know that augmentation can save lives, but the question is, how's it doing it? Well, one of the things that we learned is that lung density itself, the level of lung density, is a predictor of mortality. And these data came from Dawkins and colleagues and Rob Stockley's group, published in 2009. And what you see circled on the bottom are the subjects that had the lowest lung density to start with and their subsequent 10-year mortality. And you can see that it is much higher than the patients whose lung density started out at higher levels. And then further data from Professor Stockley's lab looked at the effect of lung density decline rate. So in other words, how fast was lung density changing over time? And there's a very interesting observation here. The three lines on this graph represent subjects that had different rates of lung density decline. So all of these subjects had abnormal lung function. They had FEV1s between 30 and 50% predicted, which is not normal. But the top group, that blue line, they had no loss of lung density over the period of observation of 10 years. And they pretty much had survival over that time. The green and the gray lines, on the other hand, these patients declined at a rate of lung density loss of about 2 grams per liter per year, less than 2 grams per liter per year in green, or more than 2 grams per liter per year in gray. And what it shows is that the greater the lung density loss rate is, the faster you're losing lung density, the higher the risk of dying. So this allowed us to try and calculate what difference the magnitude of effect we were able to demonstrate with augmentation might have on survival. And these are just projections, so this is not a survival study per se, but they're projections. One thing we did is we looked at Professor Stockley's data, and we asked the question, what's the difference in the median survival for patients whose lung density decline is greater than 2 grams per liter, that's the gray line, and less than 2 grams per liter, that's the green line. And that roughly corresponds with the difference we saw between the actively treated patients and the placebo-treated patients in the RAPID study. And the answer is that there's an extra 3.5 years of life. And if we take the rate of lung density loss that we observed in the RAPID study, which is now shown on the right side, and just project it over the course of a lifetime, you can see that it comes out to a very similar number. So in other words, with the dose that we studied, 60 milligrams per kilogram per week, which gets patients just into the bottom range of normal, there's already the potential for life extension. So to conclude, I would say that the evidence is accumulating to close the circle. There are data that have existed for a long time that augmentation therapy can result in lower mortality, and that's from the NHLBI registry. And there are data that I showed you from Professor Stockley and others that show that the rate of lung density loss is a predictor of mortality. And now the circle is closed that augmentation can affect, in a good way, the rate of lung density loss. And you can therefore expect that augmentation therapy has the potential to have an important benefit on treating alpha-1 patients. Thank you very much.